Two excellent talks.
Yeah.
I have a comment to make.
Yeah.
Dr. Rajesh, would you like to ask first or?
Yeah. I would. It was wonderful, Dr. Khanna, to have asked us to be here. And it was really a very nice experience to hear both of you. Now, I have few concerns which I thought I would share here. First is for the veno-occlusive, for Professor Eric, that does he think that his patients developed some kind of pain or painful syndrome after venous ligation? Because, the extensive surgical procedure which is required for open surgery in addition to veno-occlusion, which is done venographically, there are patients that I have on follow-up who got it done elsewhere and they came back with pain, which was persistent. And the other question is to Professor Khanna yourself. You did a wonderful job putting the stents. My question was, would you stent or would you do intervention for bilateral internal pudendal vessels, or do you think doing one side is good enough?
Okay, so let's give the first question to Dr. Eric. Is he online?
Yes. Thank you for your...
we don't see you, Dr. Eric, if you can
yes,
put
I'm
your
trying
camera on.
to switch on, but I don't have the hand to do that, apparently.
Okay, no, but we can hear you, so you can go ahead with your answer.
Yes, it's a very good question regarding pain after venous surgery. It's big surgery. It lasts a long time. One has to take care of the two nerves which are laying on the upper part of the cavernozoa. And in fact, what we can see regarding the nervous impact of the surgery is that in the first 24 hours, there is no pain. Then patients resume nocturne erections, and this is not a very good experience, although patients usually are very happy to resume with erections, and this can be managed very easily. We have a very small subset of patients, over more than 100 patients, I remember 2 of them, who still have pain during erections and intercourses more than 1 year after surgery. So it's not a lot of those patients. On the other hand, there is also 1 to 3% of patients who experience insensitivity of the gland, and this is a major problem. So all over, the neurological problem after this surgery has to be prevented with very delicate, with microscope on eyes surgery. If you do that, I think that both pain and the decrease in sensitivity are rather seldom, happily.
Okay,
Thank you.
Regarding the second question, initially when we started our program, we were just doing it on one side because we weren't sure of the long-term results. We were more worried about the safety of the procedure. But now as a practice, we stent both sides. Usually when the patient is symptomatic and is a complex ED, it's probably, we find inflow issues on both sides. And we treat them, but not in a single sitting, but we treat them one after another because we need to go contralateral and we don't want to go puncture both joints at once one time. Also, what in future we are trying an idea that, once we are trying to do most of our cases as a daycare procedure and we are trying to do most of them with a radial approach, we would in future probably be stenting both together. But the issue is we do not have long hardwares. The maximum length we have is only 130 centimeter, and sometimes, because these arteries are tortuous, we may not be able to reach there, and that is why we are limited. But we developed some indigenous guide wires and guiding catheters and sheaths, and soon we'll be starting with our program with daycare transradial system.
Quick question to Dr. Khanna and a comment for Dr. Alia.
I have one small concern.
Okay.
When you are doing a bilateral stenting of internal pudendal, and suppose if both of these stents get blocked, then I have a theoretical concern of penile necrosis. Suppose you put stents on both sides and then they have got blocked, maybe after a year, 2 years or something. Literature to, substantiate this kind of a
Because
fear?
the only literature we have is we have the Zen trial where the patients were followed up for 3 years, and none of these patients, even in follow-up, had any issues with penile necrosis or perineal necrosis. 40% of these stents had restenosis, but still their erectile functions were stable and they were improved. And probably that was because of collateralization, and most likely it must be because of collateralization. In our series also, we have done follow-up for about 4 years now, which is published. And we have no patients who have developed perineal or penile gangrene. So initially, our first 11 patients, we did it only on one side with this fear. And because of the same fear, it is still a fear because in coronary side, we are using the coronary stents in pudendal artery. And on coronary side, we know that we see late and very late stent thrombosis, and especially in convoluting stents. And that is why concepts are moving in coronary stenting from drug-eluting stent to bioabsorbable scaffolds or stents, plain stents, metallic stents with just a polymer, without a polymer with just a drug. Because these are all polymer, these are metallic stents with polymer, and the polymer has a drug coated on that. So the drug goes out in about a year's time, but the polymer stays in, that's thrombogenic. So, and it never endothelializes completely. So here, that is why what I said is intuitively with this thing in our mind, we also have this in our mind. We don't want these patients to be on dual antiplatelets for very long. We are now shifting our focus to coated balloons. You may have a little more of restenosis, but the chances of acute closure of the vessel and the closure of the vessel will not be there.
Dr. Khanna, I'm just wondering, would a Khanna LAR procedure be a better option for your already fantastic results to improve them further? What I'm saying is, if we combine the stenting procedure with veno occlusion, do you think you can improve your results even further?
Maybe in future, yes, but maybe yes. I think then the venous leak, as of now, they are doing internal pudendal artery stenting. You have to exclude patients who have venous leak. But all our patients, if they have venous leak, they are not in the study. But yes, in that case, I don't know which one to do first, because internal pudendal artery stenting, you need to put them in dual antiplatelet therapy for at least 6 months, and then go ahead with this, because they would require a patient to be off antiplatelets.
Yeah.
Let's see, Professor Allaire, what you have to
say. Yes, that's a very good point. I think that right now we really need for vascular specialists to come back in erectile dysfunction, and then we'll be able to see how we could combine treatments in patients having both arterial and venous diseases. I totally agree with Professor Khanna on this point.
I think urologists should also step in there. So we have the vascular cardiologists and urologists doing the whole thing together.
Yeah, it's what is needed is that we perform more diagnosis of venous and arterial problems regarding erections, because they are the overwhelming majority of causes of erectile dysfunction, in fact.
One last comment I'd like to make is that in your presentation, you made a very important point that there should not be any significant arterial disease for doing the venous leak surgery. Because if the problem is with the arteries, the venous surgery is going to fail. And that was the reason why the urologists failed to get a good result. But they were doing it willy-nilly.
Maybe, and I agree with you. On top of that, probably if there is an arterial disease, then there is leak. because there is no venous leak. There is no pressure high enough to occlude the venous system of drainage.
The physiological venous leak.
So even the diagnosis of venous leakage in presence of a severe arterial disease is very difficult to make.
Thank you very much. It's been very interesting, and I've enjoyed both the talks.
Thank you so much.
Thank you very much, Dr. Saxena, Dr. Goel, Dr. Taneja, and Dr. Eric.
How long do you classify that the patient failed by sildenafil? We require at least 6 months of failure. And usually we switch from one to another medication. In France, we favor tadalafil 5 milligrams per day as a very good way to see what can be obtained by medications, with, on top of that, 20 milligrams before sexual intercourse of tadalafil or with sildenafil. And then if this fails, then we consider medication as a failure.
So thank you very much, Dr. Eric. Hope you would continue joining APVIC every year. This year we couldn't do it physically, so we did it online, but the response has been very good. We have many thousand people watching this across the world, and we have 52 international faculty. Yesterday we had Roger Greenhalgh, and today we had, yesterday we also had Frank Weed and Greg Stone and Stewarts. It was a good galaxy, and also had one Nobel laureate speaking on subject related to us on nitric oxide.
Right. Yes. So much.
Farid Murad was there for a 40-minute talk, and it was attended by many, and also our chairman. So that was perfect.
Thank you for your so kind invitation.
And maybe we'll probably have an opportunity to work together on this interesting field.
Oh yes, that would be great.
Many tenants, inflow, outflow, and also drug therapy.
I would love that. Yes. Great.
Thank you so much. Thanks for your.
Thank you so much. Bye.
Yes, yes.